Excellent. Okay, well, welcome everybody to another of our distinguished speaker series talks. And today I am more than delighted to be able to introduce my very good friend, Dr. Allison Harell. Dr. Harell is a professor at the University of de Quebec at Montreal, where she holds a research chair in political psychology of social solidarity. She's the director of the Public Opinion and Political Communication Lab at UQAM. She's an associate director of the Center for the Study of Democratic Citizenship at McGill. She's a fellow of the Canadian Institute for Advanced Research. She's a member of the College of New Artists, Scholars, and Scientists at the Royal Society of Canada. And most importantly, in my view, she's also the co-director of the Consortium on Electoral Democracy. Her work uses large-scale survey and experimental data to research social diversity from many different angles, including intersectionality and gendered political behavior, multiculturalism, social networks of young people, prejudice, group cues on public policy attitudes, intergroup relations, political solidarity, and the impact of intergroup perceptions on electoral politics. To put it plainly, she's just a rock star. So I'm very excited to hear this presentation today, and I hope you'll all join me. We've been welcoming her. We can use our little hand emojis.
Thank you, Laura. That was a very nice introduction. So what I'm going to be doing today is talking about a relatively new project, actually, that was conceived, collected, and then analyzed all in the course of the last 12 months. It's a project that was done with the support of CFAR, who provided funds to myself and Evan Lieberman to collect this data. And what we're mostly interested in is really thinking about the ways in which people react to, in this case, a health crisis, and the ways in which they think about the boundaries of who is affected by that crisis. And so in the context of the COVID-19 pandemic, I think there's really interesting dynamics going on, because on the one hand, a lot of what we're talking about is a disease that we all face together, that we're asking people to make lots of sacrifices, not necessarily because their own risk is really high, but because of this larger community that we owe some sense of solidarity with. So we're asking people to mask, to stay home, etc., because we're doing this for the greater good, to protect the larger community that is facing this external exogenous threat of a disease. And I think that framing is really interesting because it contrasts with some of the things that we know about how health crises often play out over time, where groups tend to be associated with the crisis, and you start seeing stigma and blame being attributed to different groups that are more highly associated with the health crisis, especially over time. As a crisis goes on and people's willingness to make those sacrifices gets a little softer, and we start thinking about the ways in which we might start attributing blame to various communities. And so that's really the motivating factor for the study that we conducted. And so I wanted to flesh out a bit those two competing perspectives a little bit more. So if we think about diseases as sort of a common enemy, we can expect people to react by coming together. In some respects, rallying around the flag to our shared institutions as a means to address something that we see as exogenous to our community. And there's some evidence with the COVID-19 pandemic that we've seen a boost in support for our shared institutions, for governments that are leading the charge against this, especially early on in the pandemic. I think anybody who's lived through the Canadian experience situation sees that rallying has perhaps softened as well, but that in the short term, when we're faced with an external threat, often what we do is we try to come together because there is a shared common enemy, and diseases and health pandemics can be viewed like that. If you think about the public health messaging as well as government messaging, there's this really strong sense that we're all in this together. And that image of the rainbow flag that I had on the first slide I presented is really the sense that we're all in it together. We should be masking to protect this community, that anyone can spread the disease, and so that we're all responsible for doing our part to confront this external threat. And then in some work that I've done with Laura Stevenson, as also Laura French-Bourgeois, shows that the social norms of this sort of collective solidarity can really encourage pro-social behavior. So we've seen in the Canadian context, when you think that other people are really doing their part and holding up their end of the bargain, it makes a lot of people more willing to make individual sacrifices, even if they don't necessarily prioritize that collective as much as the people in their social environment do. Sorry, I'm trying to advance slides here. There we go. So on the other side, we there as being carrier of disease. And so if you think of an evolutionary perspective, health groups were seen often as disease carriers, and some of the research that's done on discuss sensitivity and its relationship to prejudice, for example, really thinks about pathogen avoidance and how others might be not only different for lots of different reasons, but potentially dangerous in terms of one's health. And some of the work that's been done around the discursive practices for health pandemics, but also with public opinion research, has shown that the ways in which social representations of diseases play out often attribute blame and responsibility to stigma. My co-author on this project, Evan Lieberman, has actually done some really interesting work where he shows in comparative context that when you have ethnically and racially divided societies, what happens are these stigma and blaming practices often lead to less intervention to actually combat health pandemics. In the case of that study, it was AIDS. But on the other hand, sort of thinking about the communities most at risk has lots of benefits too. And so we can think that targeting outreach to a particular community has the potential to create stigma, but it also has the potential to raise awareness among those who are most likely to be affected. And that recognition of risk has been shown to be also associated with people's willingness to actually practice preventative measures. And so from a public health perspective, you would expect that being aware of greater risk might actually be a really good thing. That would come with some of this information that's in our environments about who is in the most precarious positions faced by these pandemics. So when we look at the US context, and that's really where the focus of my own research is, there's been a lot of mobilization by not only the medical community, but also a lot of social and civil actors around the importance of really pointing out racial disparities in health outcomes. And the COVID-19 pandemic is no different. This is a citation that comes from researchers at the National Institute on Minority Health, at the National Institute of Health, that published in the Journal of the American Medical Association that the collection and dissemination of COVID-19 data, the race and ethnicity remain critically important to guide policy, healthcare, prevention, and intervention. So really laying it on the table that this type of information is critical for all sorts of reasons. And the media environment has reinforced this perspective. This is a graphic that comes from the COVID Tracker, which is a collaboration with the Atlantic and some universities in the US. At the time we fielded the study, that figure was actually 2.5 times that you see at the top. The rate of difference as deaths have increased over time has become smaller, but you can clearly see the ways in which this information is presented is really about disproportionate impacts among particularly Black and African American, but also Indian and Native Americans. And there's been a whole host of media coverage. This is just one example for anybody who follows some of the American coverage. There was a series that was done by CNN about the color of COVID. And this expression, if you Google the color of COVID, you'll find all sorts of health initiatives across the United States where people are trying to raise awareness about the disproportionate impacts that some communities face. As a consequence, trying to help those communities to combat that disproportionate risk. So this is the context in which we have posed the following question, really around how race-based health disparity information might influence both personal risk assessment as well as support for various policy interventions to combat the disease. And so what we did was really set up a design where we could test the impact of providing this information. So this is, as I mentioned, a collaboration with Evan Lieberman, and we collected almost 4,000 respondents in the US last fall. with a web panel that had quotas based on a bunch of demographic characteristics. And we're particularly interested in the non-Hispanic white respondents in that sample, as well as respondents that reported being Black. And so we limit our analysis in the next little while to those two communities. And the design is really simple. We have a survey. In the control condition, people take our survey, but they don't get any of this information about race-based health disparities. In our information condition, I'll show you what that looks like in a second. They receive information that shows these racial disparities. And then we have two other conditions. One where we just ask them what they think racial disparities are, but we don't provide them, at least immediately, the correct information. And then a third where we ask them both what their prior belief is about these health-based disparities, and we provide them the correct information immediately afterwards. And to give you a sense of what that looks like, in the information condition, after answering questions, a few sociodemographic questions, as well as their attitudes towards various groups in society, we just tell them. Below, you'll find the actual COVID-related death rates by race and ethnicity in the United States. And these were the accurate numbers based on a couple days before we actually went into the field. And the text emphasizes the fact that Blacks are currently 2.5 times more likely to die from COVID-19 than whites. And so we really draw on that contrast. In the prior belief condition, we give people the same type of graphic, but in this scenario, we actually tell them what the average rate is, and that's where all of the bars are listed at 54. And we tell them, this is where the average is. What do you think? Where would you estimate those death rates to be? Obviously, we have very little expectation that people are going to get these answers correct. But what we're really interested in is the ways in which they move those Black and white bars apart. So do people think that there are differences in death rates across racial groups? And I'll show you how we operationalize that sort of prior belief later. And again, in that corrective information treatment, people receive this one followed by that correct information graph. So they can see what they think it is and then what it really is based on the statistics that are currently available. Our outcome measures are really of two types. One is based on assessments of risk perception, and all of these are scales based on a series of questions. Risk perception is about my own and my sort of social network's risk of contracting the disease. And then the other 4 outcomes are really about what we should do about it. So that we have a scale about whether or not government should be doing more to combat the pandemic. We have questions about support for all kinds of public health recommendations, if they should be mandatory, social distancing, hand washing, etc. We have a reverse coded scale about whether or not these health measures are actually infringements on personal liberties. So this is a reverse coded scale about the sort of being anti some of these intervention measures, but for reasons related to individual rights. And then a final scale that really focuses on social policies. So support for unemployed workers, extra support for people disproportionately affected by the pandemic. And our expectations are formalized in our pre-analysis plan, but the gist of it is that we expect white respondents to see less risk and Black respondents to see more risk when they're provided with this information. So pretty simple of updating one's risk perception if we know that we're in the group that's less likely to be affected, or we're in the group that's more likely to be affected by the pandemic. And then I think this is where our research becomes more interesting, is that we expect among whites that their reaction to this is really going to be dependent on how they feel about Black people. And so we expect those who have prior higher levels of affect towards Black that we measure through a feeling thermometer that was asked before the treatment to be more supportive of all kinds of policy interventions, but that those who have negative affect towards African Americans are going to react with less support. And it should be said, we expect affect to actually have an impact on all of these outside of the experimental treatment. What we're really interested in focusing on is whether or not providing that race-based information can accentuate those effects. And we expect that these effects should be highest among people for whom the information is new. So it's not just a framing effect, bringing up race, but something about the content of the information that we're providing, correcting misperceptions as well. So that's the basic gist of the experiment. I'm going to jump right in to some of the results to give you a sense of what we observed across these different treatments. And I'm not sure, I know it's an interdisciplinary group. If there are questions or precisions that you want to pose during my presentation, please feel free to do that. I'm not sure what your norms are at NEST. So what you have here is just the distribution on those that prior belief question. So as you can see, people gave all kinds of answers to where they thought those death rates were on that 0 to 100 scale for per 100,000. What you see in that black dot that says default, that's the 54-54, where everybody is placed if they didn't move the scale anywhere. The actual was much closer to above 80 for Black Americans and then below 40 for white Americans. And so what we were interested in trying to capture was really people who moved those two bars apart. And so the way we ended up doing that was looking at one standard deviation departure from the actual difference and trying to code people as a very generous estimate of correct or people who really underestimated the gap in that. And then we did one correction for people at the very low end of that scale to make sure that the ratio was correct so that we could capture some of those people at the very low end of the scale that still place Blacks higher than whites. And so the red and the blue colors in this graph are representing who were considered underestimators and who can be considered to get it right. And there's a few interesting just observational aspects to this. One is that Black Americans in our sample were much more likely to be coded as correct. And again, it's a very generous definition of what correct might be, but there was clearly a recognition that their community was disproportionately affected by COVID-19 deaths compared to whites. So among Blacks, it was about a third that were coded based on that coding as underestimators, whereas about half of whites were seen as underestimators in that graphic. So it's a bit of context. I think it's also interesting to know that the distance on that scale for Black deaths is also really correlated with how people felt about African Americans. And so again, one of our key moderators is Black affect that we operationalize through a feeling thermometer towards Blacks. And so we know that feelings towards Blacks also puts people higher on this scale, and that's a context that I think is really important to take into consideration here. So again, our expectations are really of two kinds. One is about risk assessment, and one is about policy interventions. Our basic hypothesis that we would find an effect of updating for Blacks and whites didn't really bear out in the data. Except when we looked at particular type of white and Black respondents. And so on the left side, these are just marginal effects plots based on our models. I can give you the full models if you want big tables. They're at the end of my presentation if anybody has specific questions about that. But among Black respondents, first of all, knowledge about Black and white health disparities was really high. And so in the full model, we didn't actually find any effects that were significant. When we look at the difference between those correct estimators and those underestimators, though, among Black underestimators, which were about a third of African American respondents, providing information about race-based disparities increased their assessment of risk, of risk. And this is important, and I think it's in line with a lot of that mobilization around making communities aware of disproportionate risk, because there's lots of expectations that risk assessments are going to be correlated to actual behavior. And so if you're aware that your community is at risk or that you personally are at risk, you're more likely to take preventative measures that are actually intended to combat and to counteract that risk. Among whites, recall that our expectation is they were going to downgrade their risk assessments if they found out that whites were particularly unlikely to die from COVID-19 compared to some other racial groups in society. And we didn't find that at the general level. The only place we found it, and this wasn't part of our hypotheses that we had set up from the get-go, was among people with really low racial affect. That was the only part of the sample that really downgraded their risk assessment when provided with the information that we had in our study. So I think this is interesting. It's a bit positive information. Information was already really well known among the community most at risk, but when we corrected that information among those who weren't necessarily aware of the extent of that risk, they upgraded their risk assessment. And so this is sort of that positive side of making this type of information really well known, particularly among the communities that are most at risk, with a little bit of hesitation among those with really low racial affect among whites about downgrading and potentially then not doing the types of measures that they need to be doing to combat the greater health risk within the community. So I think those are interesting and somewhat promising results. When we turn to people's attitudes towards prevention, again, I think it's important to know that sort of racial attitudes as well as partisan attitudes in the US are going to be strong direct predictors about how much people want to do about this. I don't think you can have had observed American politics over the past year and not realize the extent to which those attitudes are correlated with how people reacted to the pandemic. What we're particularly interested in, though, is above and beyond that relationship that we observe in the population, can providing this information shift people even more? And so again, these are marginal effects of receiving the information or not on the 4 scales. So we have the combat scale, our public health scale, whether or not this is infringing on individual liberties, and then support for more larger social policies that are really targeted at combating the effects of the pandemic. And then we're using the feeling thermometer towards Black, or what we're calling Black affect, as the moderator here. And we find results that are really consistent with what we expected. So on the high end of that racial affect, for the combat scale as well as for the infringement scale, we find that they're going in opposite directions. So let me rephrase that. So people with high affect were more likely to say we should be doing more when they found out that the risk was greater for African Americans with that information treatment that we provided. The opposite is also true. At the other end of the scale, people downgraded their assessment of how much we should be doing at various levels when they were provided for this information. And that's above and beyond the effect of that affect variable's direct effect on those outcomes. And so the simple provision of that information we find has effects, at least in the short term in the context of this survey, on people's willingness to want governments to do more. The direction for our public health scale as well as our COVID relief scale go in the right direction, but they're not significant. And then our opposite coded variable about whether or not this is an infringement on liberties goes in the opposite and expected direction. If you have high racial affect towards Blacks and you find out about the difference, you're provided that information, you are less likely to say that these public health measures are infringing on your personal liberties. So this is largely consistent with what we expected, not always significant despite the big sample, but we think they go in the direction largely of what we expected. And if you'll recall, we had that secondary expectation around whether or not it was new information. So I think one of the things that we face and has been faced in previous studies that have tried to look at these effects is that people were just already aware of the environment in which they were in, or they just had expectations that these types of disparities would be there. And so we were really trying to isolate the effect that the information itself was having on attitudes. We haven't necessarily done it perfectly, but one of the ways we thought we could get at this is by looking at people who really underestimated, again, these types of effects. And so I'm just going to show you, it looks almost the same, but it is a different graph. So this is just this exact same results, but limited to those who had underestimated. Everything's in the same direction as we expected it, but the results get a little bit stronger. We start seeing a little bit more consistent effects at the 2 ends of the scales across here. And it's more consistently significant in the models that we had provided in the paper that I'm happy to provide to anybody who's interested in reading it. And so what does this tell us? I think it tells us some really interesting things about the ways in which people are reacting to race-based information about health. and the context in the United States actually more generally. So we know that knowledge about this disparity is already really high. It might be not fair to talk about knowledge, but perhaps expectations of what the difference would be. Because again, we didn't necessarily have really strong a priori expectations about how able people would be to make these types of estimations. What we were really interested in was whether they could recognize that some groups had a disproportionate probability of dying. The backdrop is that Black affect and partisanship, both of these are really strong predictors of attitudes towards what we should be doing in the pandemic. We know that Democrats are much more likely to support these health measures, and that Republicans, for the most part, have been more resistant to some of these types of interventions, both in the context of the pandemic, but also in terms of state intervention more generally. The results we have really shows that affect moderates reactions to race-based COVID-19 death rate information. Among low affect whites, we saw reduced risk perception from this information treatment, but more support among high affect folks for intervention. And that's really that double-edged reaction to this information. The bright side, I think, part of the bright side of our results really focus on those among the Black respondents in our sample for whom providing information increased risk perception in a noticeable way if they did not already recognize the extent of that disparity within the population. So more generally, I think what this tells us is that this race-based health disparity information is really a double-edged sword. On the one hand, it can create cross-group solidarity and increase risk perception among high-risk groups. And this is really something that we should be hoping for. If you're creating a public health campaign, what you want to do is get everybody on board in the context of a pandemic to do what they need to do in order to counter its spread, and that this should be particularly important among groups that are at highest risk. So there's some evidence that we're coming together when that cross-group solidarity is possible. And for me, the way I read these results is that that's possible when there's already some prior sympathy between groups. So making people aware of disparities and inequalities when there's prior sympathy can move people to be more interventionist, more willing to make sacrifices. At the same time, it can also lead to some really less than ideal intergroup dynamics, where if that prior sympathy between groups isn't present, what you get is resistance towards the types of measures that are going to be most effective at combating it, and creating a much more polarized environment in which those are being debated. And I think that's a lot of what we're seeing in the US context over the past year now, is really this separation of the ways in which we're thinking about this pandemic in terms of the communities that are most at risk. And I'll just end on thinking about the ways in which this might work for other groups. And so one of the things that we thought about very much early on was whether or not African Americans, there was something specific about that group in the United States context, or if we could find other groups, if we could moderate effects based on how people felt for older Americans, for example, another very high-risk group in the US context and as everywhere. And I think something that is really interesting here is that the existing cleavage is really what's important. The larger literature on welfare state assistance or all kinds of government interventions tends to view the elderly as well as children as particularly deserving groups for intervention, all kinds of interventions for government support. What's interesting here is really this idea about it being a divided society in which there are pre-existing biases that can be activated when this type of race-based information is provided and really becomes dominant in the media environment. And so that's the type of results that I think provide some nuance to the ways in which we should be thinking about public messaging around getting people to actually do what we want them to do during a pandemic, which is following health recommendations, but also willing to be generous towards those that are most affected by these types of crises. And so with that, I'll tell you thank you. And I'm really looking forward to comments and discussions and questions.
Thanks so much, Allison. So if I remember correctly, we are to take questions in chat, and then we will go in that order. Correct me if I'm wrong, Leo or Vicky. So if anyone
Feel free to use it in chat, or if people just want to raise their hand and ask questions.
Okay, perfect. If anyone has any questions for Allison? Oh, Vicky, there you go.
Where's Allison? Oh, there you are. Thank you. That was a great talk. And it's really sort of interesting to think about these dynamics. This is maybe a question you would think is obvious coming from me, but the Black affect item is a pretty explicit item. And so it's not necessarily reflecting what people feel, but what they're admitting to feeling, right? Mm-hmm. So the people who are willing to say that they have low Black affect maybe aren't only prejudiced, but also don't care that they're prejudiced, which is a bit different, right? Because they're willing to say it. So I just wondered whether you thought more implicit measures might produce the same or something different.
Yeah, so that's a great question, one that we mulled over a lot, partly because we wanted to measure it pre-treatment. And we thought about things like racial resentment and other measures. And because we're kind of queuing racial considerations, we wanted something that we could ask in a battery with a bunch of other groups, which is how we asked this, that was kind of, not as obvious about what we wanted them to think about going into the experimental treatment. And so we ended up going with the thermometer, for better or for worse. We ask a racial resentment item post-treatment as well. Sort of the classic racial resentment battery from the US. And that correlates with our Black affect in ways that you would expect. But again, my reaction to that feeling thermometer is it's really noisy. And so the fact that we find anything with a measure that's noisy, I think suggests that if we had a better measure of pre-existing prejudice, that we might be able to get more consistent or stronger effects. Whether or not people low on that measure are different from people who should be low on that measure but just aren't going to say it, I think that's an excellent question, and I don't think it's one that our data can respond to. Having done survey research for a long time, I'm less worried about respondents not willing to tell me things, because we see so often people willing to answer questions that on their face value look really offensive. But I think I think it's a fair comment. It's like Rod.
Yes, thank you. I also much appreciate your talk. I don't know this literature at all, but would it be similar for people's attitude towards universal health care? That is, would these prejudicial attitudes and the knowledge, having more knowledge, would it have similar influence on people's attitudes towards universal health care?
So that's a great question. We did some pilot testing before we went into the field with this study. And one of our guesses in the pilot study was that this would have larger impacts on support for redistribution. In our pilot study, we found very little evidence of that, partly because we just weren't able to move people's attitudes. With that type of information, they were being predicted out by partisanship and other things. But that being said, I think part of the reason people react to universal healthcare or social assistance or all kinds of social policies, especially in the United States context, there's an immense amount of literature that talks about the ways in which these policy areas are racially coded. And so they're activating considerations of the groups that people think are benefiting disproportionately from them. And so I've done work on this in the US and Canada and the UK, but there's lots of others that have shown that racial prejudice predicts support for social assistance and other types of welfare programs. But also you can decrease that support further by activating those considerations that the recipient of them is actually African American. Given the ways in which Obamacare and the debates around universal health care have overlapped on the considerations of race, as well as the ways in which racial attitudes have sorted onto partisanship in the United States over the last 2 administrations. I wouldn't be surprised that you would see the same dynamic with universal health care specifically.
Thank you.
Any other hands?
I see Marlon?
Yeah, thank you. That was a very interesting presentation, talk. I'm just wondering, to what extent do you think that elite messaging regarding the pandemic may have affected or primed attitudes during, after the pandemic onslaught? Because it seems like, for example, in America, conservatives, or rather the president, has been trying to racialize the pandemic in a way that perhaps other world leaders have not done so as explicitly. Do you think that these attitudes are more latent before before the elites come into this dimension in their particular response on this crisis?
So I think the US context is a little bit unique, especially because it was so polarized early on, and you didn't see that necessarily elsewhere. But at the same time, I'm not sure if you wouldn't find the same effects elsewhere. If you really activated disparities in the Canadian context, for example, we know there are disparities, and there's increasing information coming out about those disparities as they affect immigrant communities, but also Indigenous communities in terms of risk levels. And so if you start really hammering home that message, either through the media or through elite messaging, I suspect that people who have prior negative attitudes towards them may become less supportive of collective action through government intervention, but also following health recommendations. So in that sense, I don't think it's necessarily specific to the US. I think depending on the distribution of those attitudes within a society, that they could be potentially activated. And that's one of the longer, sort of the bigger messages that we were trying to really wrestle with in this study is, I think it's important to know where inequalities exist, but I think the caveat is important, that really hammering that home goes counter to the message, and an effective message, I think, that there is a collective problem that we need to face together.
Thank you.
Other questions? Jordan.
Hi, Allison. You may have explained this. I missed the beginning of your presentation. Could you clarify the structure of the Black effect measure?
In terms of how we asked it?
Yeah, the questions you administered. What's being captured there?
We asked about how warm or cold they felt towards Blacks, whites, and then a host of other groups on a scale from 0 to 100. And so it was really a feeling thermometer.
Thank you. A second question then.
Okay, Jordan, second question.
Do you have any plans for follow-up for this and additional things? I guess I'm just thinking about the question that Rob asked earlier, and what would happen if you framed your question in terms of, rather than Black individuals having X more cases, but being X more transmitters of COVID, and see if that would be a stronger treatment.
Yes. I think if you started telling people African Americans are the ones spreading this disease, that we would have an ethical problem doing that in a survey. But it's also a question of, I think that's strong, and it gets much more at the stigma argument in the larger literature. We wanted to stick really closely to what was being done in the media. And so we used public information and actual rates and just provided that information. But I think there's been increasing worry about the ways in which that kind of stigmatization is going towards Asian Americans, for example, with increased crimes directed at them, and the association that the Trump administration especially made between the disease and China. And I know Vicki and Laura and others at NEST have done some work comparing Canada and US attitudes on these aspects. But I think that association is problematic for lots of reasons, but it's not surprising that you'd see increased hostility towards groups that are being blamed for the spread of the disease. I don't think that's how the discourse around African Americans has been playing out, though. It's not necessarily that they're the spreaders as much as there's a legitimate, goodwill to understand racial inequalities and health outcomes to raise awareness. And I think even that goodwill type of gesture and wanting to understand those inequalities can have outcomes that you might not expect or desire from that kind of public health campaign. Mathieu?
Hi, thank you, Allison. Very interesting. I just have a quick question about, so people could put ranges between 0 and 100, and I was wondering how this choice may have affected some of your findings in some ways. If you had given smaller ranges, because I suppose some people put them at 0 because, they think that COVID does not exist, and other people just max the scale. So how did you come about the choice of 0 to 100?
Yeah, so we had a lot of difficulty thinking about how we were going to actually do these treatments and what would be something that was accessible. I mean, we know numeracy among publics is not high, but given that the actual average was around 54, we figured going about double, suggested that it was a lot and low as little, partly because we didn't think people actually knew where the numbers should be. We just wanted them to be able to move them, but particularly move them apart. And so that gave people a long range to do that. It's a really interesting question about whether we did it from 0 to 1,000.
Yeah, I mean, I don't know how it would affect the results. I mean, it's an empirical question, but for sure it has some effect, I guess, somehow. But yeah. Thanks, very interesting.
Yeah. And I think one of the things is that we didn't actually care where they placed, like that they got the number right. We really cared that they moved them apart. And so my sense is if we change the scale, the people who put them apart in sort of a sensical way would still be capturing the same type of dynamic. Partly because, again, we really had no expectation of people's accuracy. Mm-hmm. We wanted to get their sense of disproportionate impact.
Good. Thanks.
So maybe if I don't see any hands right yet, but just if I can maybe ask a question myself, and sorry, I had to step away for a call, but did you mention if you've looked at any other groups outside of the US context? No,
we haven't. Our main concern was really about white-Black differences in the US. We do have, in the sample, we have Asian Americans and Hispanic and Latino Americans. And you'll have noticed in the presentation, we provided multiple groups. So we've started to look at whether those groups shifted the risk assessment similarly to Black among underestimators. We don't find much in the way of effects, partly because those groups are smaller in our sample as well. We intentionally oversampled Blacks because that was part of our main hypotheses. So that's a direction that we're looking at. Our future research right now is really looking at some of our other variables and focusing on the non-white respondents in the sample. One of our intuitions was that providing this information might increase a sense of shared fate, for example, among Blacks or Hispanics or Latinos, because they're being presented as a bulk group that faces a health crisis together. There's some indication of that, but we're really early in those analyses right now. But I think it would be fascinating to do in the Canadian context, for example, to see if you could get those same effects, even if you might expect the underlying distribution of attitudes towards the groups to look different.
Yeah, And the idea of the shared fate, I mean, almost like a rainbow coalition, right? If everyone is in the same boat on that end, even though it's so distinct. So I would love to see what it would look like in the Canadian case, maybe. Mm-hmm. Vicki? Yeah.
Yeah. Allison, I wondered if you had thought at all about primes that might reduce the effect.
Mm-hmm.
So it would be kind of fun. I mean, now that you've shown this effect, what do you do to get rid of it, right?
Mm-hmm.
So I just wondered if you've thought of that at all and what you might test out.
Yeah, so that's fascinating. I think the direct effects of some of these measures on those outcomes, I think, will be hard to get rid of. But whether or not we could get rid of the effect by framing it differently, that's a really fascinating question. Going into it, I think collective framings are really useful. So I don't know what that would look like, though, in the setup that we have. My sense is that talking about it as a shared problem that we all face together is effective at getting people to come on board. And so that is my intuition, and that's why that sort of framing about we're in it together and what can we do to help each other is kind of Pollyannish, but at the same time, I think it's really effective to start getting us to face a collective problem for which our individual risk might be really low, but that we need everybody to do their part in order to actually be effective at these public health campaigns.
So something that might use a common in-group manipulation. Maybe there's some common out-group out there somewhere outside of the US or something. I don't know.
Yeah, no, absolutely. So I mean, I think framing it as a problem that China caused is not going to create what we want necessarily, but that would come in outside of that we're caring about right here with other repercussions. But that would work, I think. But thinking about framing it around all of these people being, you know, true Canadians or true Americans, maybe that could be effective.
Sounds good, thanks.
My daughter agrees, clearly.
I love the idea of getting rid of the effect, or seeing what you can do to mitigate the effect, because it's my own commentary. So much of what we're seeing, I think, with health measures is about perceptions and how things are being framed and marketed right now. So that's great.
And I mean, I think our results also say that you're probably not going to find them if you don't start moderating by these attitudes, because they're washing each other out. They're pushing people in different ways. And so in the general sample, you don't see them. And so you might be hiding some of the beneficial and not beneficial effects by not thinking through how people are receiving that information.
Yeah. Anyone have any other comments or questions we can pose to Allison?
I've convinced you then. Or it's just a Friday afternoon and we're all tired. I'll interpret as a former.
I think that's a fair interpretation. Definitely. I mean, my head always spins with trying to think about how these dynamics would play out in other contexts. I mean, certainly the black-white divide and the impact for social services and the way that these attitudes have played out in previous, previous looks at public policy and stuff like that is very, not necessarily unique, but certainly dramatic. And so, the question I guess I would think about is, do we see the same kinds of attitudes in a less divided society, and it's really that the coalition and of different groups that's fascinating. So if a society where there is maybe more smaller minority groups, I guess, right? So they're more varied within them, and how do you create that? Or is there a sense of that sharedness? I mean, I'm thinking about the messaging around Toronto right now, and certainly in the Canadian communities, and it's not so much by specifics other than, you know, that visible minority category that's so problematic in the Canadian context? And what does that actually mean? And what would those results look like?
Mhm.
Vicki?
Sorry, I thought of another question, which is, and this is probably maybe not what you want to do, but I could think of things that might exacerbate this and might make even those low prejudice people show these effects, which is what's going on right now, where people are talking about who's going to get the vaccine first in Canada, where it seems like it's a scarce resource. And, you know, last week they were talking about Black Canadians maybe should be, like, I think the National Health experts were saying Black Canadians should get it first.
Mhm.
And I can see a lot of resentment against that.
Yep.
Or, you know, Indigenous communities have got it first.
I was thinking about Indigenous communities.
Yeah.
And that's a great suggestion. Now that vaccines are actually rolling out, they weren't when we were in the field, but creating scarce resources, I bet you could actually activate these in ways that maybe you would still get that sympathy on high affect. I'm not sure.
It's pretty personal at this point, right?
Yeah.
So.
Yeah, no, that's a fantastic suggestion for a follow-up. That's you.
Yeah, just a quick question. I'm trying to think about your experimental design. And if I got this right, I was curious if you compared like the two columns. That is, in one case, you know, people were free to place them wherever, and then other group, you gave them the exact positions. So that effect there as compared to giving them anchors first, you know, because you place them at 54, all of them, versus then another group where you kind of correct that placement from that original anchor of 54. And I was wondering did you compare those two corrective effects in some ways, and what did you find?
So we only have one corrective effect because people either got the information or they placed them on that bar, and then there's only one setup where they place them and then they get the corrective information. So are you asking if we looked at the treatment separate, combined?
So I was thinking there was one treatment where people are just free to place the scales wherever they want. So that's kind of like your control group, no?
We have some where they got to put their answers on there wherever they wanted them, and then we do correct them. We give them correct information at the end because we felt obligated to, but not until after our other dependent variables. And so we do see some effects for prior belief. That's our prior belief treatment. But the main clear effects are really with information. It wasn't necessarily about them placing them wherever they were going to place them. And so what we end up doing in the model is really using that as a moderator to figure out who knew the right information before and who didn't.
Okay, good. Okay, thanks.
I have a comment more than a question, really. But during this, during your talk, I was just thinking the whole time about GRID and the AIDS epidemic, and how the framing of, like, they originally called AIDS, they literally called it like a gay acquired immunodeficiency syndrome, and how the framing of that explicitly referenced a specific marginalized community caused, I think, elites and institutions in society to not even make a real attempt to combat it. If anything, some figures were like, oh, well, they're a sinful, evil lot in society, and this is an act of providence. I'm just wondering what caused the destigmatization of AIDS? What caused people to start thinking it as, oh, it's a thing that targets, just gay men or whatever, marginalized groups that are disproportionately affected by this? Is it just waiting out and go like, uh-oh, we're now starting to get affected by this? Or was there some sort of, reason that caused people to actually care about the containing this disease? or was it just pure self-interest at the end of the day that, may have caused a reformation of the opinion towards that?
I think a lot of the research around the epidemic is what motivated this research, because of the ways in which it was stigmatized around African Americans, but also the gay community, and it played out differently in different countries around sect and race and other things. And I think that's the motivation for it. I'm not an expert on what happened during those in terms of the public mobilization, but I think it's partly that negative attitudes towards LGBTQ communities also shifted with that destigmatization. And so there was increasing support for those communities as well, destigmatizing not only the disease, but the communities that it was associated to, as well as talking about the ways in which it affects all kinds of people. And so shifting back to that, we're all at risk and we all have to do our part, and there are things that you can do, and it's not just them, and it's not just them that we don't like. So those are the steps I think are important in there.
Well, saying I'll give a last call, so to speak, on a Friday afternoon. I don't see any extra hands, so I will say I'll take this opportunity to say thank you, Allison, for presenting this really timely, and brand new research. It was great of you to join us this afternoon and get us to think a lot about some of these dynamics that I think, as you and Vicki were mentioning, is going to become even more dramatic as we get into the who gets the vaccine first, second, third, et cetera world. And so it'll be even more pressing. But thank you very much. And thank you to everybody else for joining us today.
And thank you for the invitation.